Good evening, everyone. This is Len Sierra with AnCan. This is part 2 of the summaries of presentations given at the Prostate Cancer Foundation Scientific Retreat in September 2021. And we're going to start with Jimmy Greenfield. And Jimmy, just lead off by telling us what you're going to talk about and then go to it.
All right. Thank you. I'm Jimmy Greenfield, as a lot of you know, and I've been chosen to summarize the exercise-focused portion of the survivorship segment of this 28th annual Prostate Cancer Foundation Conference. And I'm going to share my screen with you and share some screenshots that I took and talk about the parts that were pertinent to that discussion. And that's what I'm, and maybe editorialize just a bit where I see fit. Fitness, there you go. So I'm going to get ready now. If everyone's ready for me to start. So I'm sharing my screen, and you should see that, and you should see this first picture. Everybody good with that? Can everyone see the screen, session 5 and all that?
Yep.
Good. Okay,
Yep.
I'm going to start.
Fine.
Okay, so anyway, there were all these different things. It started out with an introduction by the moderator. Many of you know Dr. Alicia Morgans, who personally I don't mind watching her on the screen and talk all day. I'm basically in love with her. She's amazing. And never mind that, though. She introduced everybody, and they spoke in succession after she did. Her introduction didn't get into specifics except that she did talk about the Ember Watch, which a lot of you have enjoyed a lot. So I thought that was interesting. She seems pretty excited about that. And I know that a lot of you guys are, the Ember Watch for hot flashes. So she then turned it over. And I'm not going to go over what Dr. Charles Ryan talked about, which was the cognitive function issues and what they're trying for there to deal with that. And neither Dr. Stacy Lowe talking about sleep dysfunction or Dr. Ravi Puring talking about the cardiovascular and bone health. But the only reason I say I'm not talking about those things, of course, I'm talking about all kinds of those things, just not, they weren't specifically talking about exercise, even though it affects those things. So I am talking about what Christina Daly-Conwright was talking about. She was speaking about exercise oncology, and a man named Joel Poynton, who's a patient advocate, talking about his experience on ADT. So starting with Christina Daly-Conwright and her work at Dana-Farber, she's talking, of course, as you see, of exercise as medicine approach to optimize treatment. She talked about the history of exercise oncology last 100 years. 100 years. I mean, all I know is that it wasn't that many years ago when oncologists used to tell their patients to take it easy, don't exercise too much. What was that thing you just, Len was just saying about hearing you shouldn't shovel snow if you're more than 45 years old? I never heard anything more ridiculous in my life, but hey, maybe that's could work and kill a whole bunch of, throw the baby out with the bathwater on the way. But anyway, this has come a long way, obviously. And when you're talking about, as she says, what's exercise oncology, very simply, using exercise to enhance the lives of people diagnosed with cancer, that's us, or at risk. The guidelines she mentioned, that's 2010 guidelines, 2019 guidelines. What changed in 9 years? Well, not so much. The two kinds of exercise we want to be sure we're getting is aerobic and resistance exercise, obviously. 10 years ago or so, 150 minutes of moderate intensity or 75 minutes of vigorous intensity was suggested. So the 75 of vigorous intensity was offered as a sub for the 150. This 150 is thrown around a lot to the general population as a recommendation. But of course, this is for cancer patients. But this has been changed to 30 minutes moderate intensity 3 times a week, which is a little bit less than the 150, obviously. But it doesn't say anything about that equivalent. I think what they're really trying to do, first of all, vigorous intensity is a really, really arbitrary thing. I mean, one person's vigorous intensity is another one's easy. So the 30 minutes of moderate intensity 3 times a week, it's just getting people out there, making it simple enough that know that you just start. I always say this: start low, clear the bar, come back for more, make yourself want more, and don't try to do too much. You get frustrated and quit. Resistance exercise, same thing. A very modest goal for most people, 2 times a week, 30 minutes per session, 2 to 3 sets. That wouldn't be enough for me, but I'm very experienced. And so for someone who's not, or just coming back or just starting to exercise, this is a great guideline that essentially didn't change much in the 10 years of guidelines from the American College of Sports Medicine, and it'll change some more over time, as she said, but that's what it is basically now. We know that the exercise does all these things. This is not conceptual. This is fact. These are all things that are data-driven, proven, and the ones that aren't quite with these little asterisks just strike me as a little bit funny. But you see it reduces chemo brain. This includes Lupron brain. It improves your mood, sense of control, aerobic capacity, improves your immune function, your pelvic floor function. Well, not in my case, but you can't have everything. Improves the balance, reduces recurrence. Amazing, reduces recurrence. There's a lot of stuff coming out now about how it slows tumor growth, it reduces recurrence, it delays time to all of the things that we don't want in cancer and non-cancer related. Reduces the fatigue, all these things. And the ones that are minimal evidence, improves tolerance to treatment. I mean, those of us who have done it know that it does. And improves efficacy of treatment. I'm willing to bet that that will be proven out pretty soon too. So as the old song says, you don't need a weatherman to know which way the wind blows. And I think that's pretty obvious that all of these things are good effects of exercise. The problem is, of course, as she says here, this is quite a striking number. Less than 15% of cancer survivors are physically active. That is a really low number. That's a lot of people sitting around, a lot of people laying around, a lot of people being depressed, a lot of people losing their physical ability and headed towards atrophy of such a major proportion, especially when we're on ADT and drugs like that, that this will take us down. In combination with this, unfortunately, we see 65% overweight or obese. We know that half the people in the country, fully half, are either diabetic or pre-diabetic. And being pre-diabetic, unless you work hard to reverse it, it's like being a little bit pregnant. So this is very serious business. And this is what leads us to a lot of trouble. It gets exacerbated by the ADT every time. Well, we also know that, age-related decline is a reality. No old guy is going to be surprised to see this going down like this. But of course, in cancer-related decline, more steep and a shorter time. What mitigates it though? Exercise. Exercise is the main thing that will mitigate these declines, without question. Now, I'm not getting into diet and spiritual life and a wonderful marriage and some of the things that we enjoy or try to enjoy. I'm just talking about exercise, but it's a big, big deal. We know what ADT does. We know it does what it's supposed to do. I'm not going to get into that. Nor am I going to get into what's called complications. We know that the ADT decreases lean mass, increases adipose fat, especially belly fat, decreases physical function, and reduces thus the quality of life significantly. This is fact. Here's a nice picture she put with this beautiful illustration of a fat man, pointing out the elements of metabolic syndrome, which we know any combination of these, and especially all of them, and they all kind of like work, in concert a little bit to produce a very distinct risk for cardiovascular disease and type 2 diabetes. Now, most guys, I think, know, almost more people know their blood pressure than anything else, because every time you go in the doctor's office, they take your temperature, put you on a scale, and slap the blood pressure cuff on you. Most people will know, even informally, that don't know much, that 130/85 or greater is too high blood pressure. But these numbers, I think everybody should know these numbers. Everybody should know their numbers. It surprises me when old guys don't know. Of course, prostate cancer guys, if they don't know the Gleason score, they don't diagnosis, they don't know what their PSA was, they don't know what PSA is. This is very troubling. But it's also troubling that we don't know these numbers. We should know HDL, high density lipids, called good cholesterol. If that's below 40 in a man, that's a warning sign. This is deconditioning. This needs to be higher in almost every man to promote good health. This is, of course, glucose greater than 100 milligrams deciliter. I guess that, when it gets high enough above that, you start to have insulin resistance. It's bad news. Prediabetes, diabetes, this is the gateway to that. And so this is what we want to watch there. The waist circumference is the simplest one that we use of over 40 inches, if your waist is over 40 inches, I don't think you have to be told that that's a lot. And the triglycerides, I think this is a pretty high number. I wouldn't want to see my triglycerides anywhere near 150, especially greater than that. And the reasons for that can be, sussed out if you're not clear. So those are the things that are all exacerbated by ADT and that are could be avoided. How? Well, one of the ways is, of course, you're talking about periodized resistance training. This is really the same as progressive resistance. All these programs do, they take people and they put them on a 12-week program, especially if they're deconditioned or out of shape. And you can see that, 60% of one RM means 1 rep max, the most weight you can move one time. And you take 60% of that, 15 reps, 3 sets, do that the first couple of weeks, and then that, as you see as it goes along, the weight increases and the number of repetitions per set decreases. And this produces the holy grail of hypertrophy, which just means enlarging of muscle cells and makes you stronger and all the good things that come with it. This I only put up because I'm reminded of something I'd kind of forgotten about, circuit-based interval training. This is kind of like old hat, but it's very effective. I think this kind of got overtaken in the popular culture by something called HIIT, high-intensity interval training. CrossFit was the major proponent of that to got the craze going, but this preceded that. And it's almost the same thing, it's just not as intense. You move from one machine to the other or one weight exercise to another with little rest in between, and that way you're able to keep your heart rate up and do the strength training simultaneously. Can be very good. This just an illustration, like the reason that this is such a dramatic drop in metabolic syndrome risk is because this was an exercise study with sedentary, overweight/obese prostate cancer survivors. So these are the guys that are kind of at the bottom. But I always say the farther behind the 8 ball you are, whatever you want to call it, the more out of shape, the more deconditioned you are, the faster you improve. This should always be heartening to anyone who's getting started. You're going to see the most improvement on the front end. If you took a professional football player and put him in the gym with a 110-pound, 5'10" string bean 14-year-old, and they worked together for 6 months, the football player would gain about 2% and be happy that he did, and the kid would be transformed and gain 30 pounds of muscle because he's further behind. So it should be inspiring. I don't know if it is or not, but where is it going? Virtual health exercise. This is the online stuff, the Zoom stuff, the interactive stuff on the internet that got sort of heightened popularity by pandemic, but this is definitely a big deal, and I think it's obviously a very valuable part of the future. Exercise modalities means different kinds of exercise, and within cardiovascular and strength training, there are many different forms, many different techniques, all of them good, some of them very different from one another. And so you just, the more you learn about those, the more you might find what it is that you like to do most. And sometimes something that you really enjoy is just as good as something that you hate. So it's good to suss that out. The exercise guidelines will change over time. All these good things, as we know, treatment efficacy, muscle quality, tumor biomarkers, these are all things that are going to be proven out in a way that, according to Dr. Ryan, which I watched, even though I'm not commenting on what he said that as exercise as medicine gets more accepted, more mainstream, and the evidence is strong, the evidence that we informally already know, then insurance will pay, like they do in Australia, he says. I don't know anything about it. But, there will be free programs and a proliferation of easy to obtain help in this area will proliferate. And I think that obviously is a good thing for us. If you want more about what she's doing, I'll put this in the chat later. I forgot to, but that's Christina DeLay-Conright's work at Dana-Farber, which this presentation up to this point was comprised of. Okay.
Thank you, Jimmy. Oh, Jimmy?
Yeah, sure.
Yeah, we're going on the 20-minute mark here. And
Are we really?
Yeah.
Well, not since I started, but okay.
Well, I don't know what time you started, but I know we've got Herb and John and Mark. Can you wrap it up in a few minutes?
Yeah, I'll wrap it up. I'll take a few minutes only.
Thank you.
Joel Poynton simply talked about his an unsatisfactory experience with his urologist and how he couldn't find any empathetic trainers or any programs that seemed to to speak to him directly, but he finally found one. This gentleman is a retired military guy, came up with an online program of bands and body weight resistance training. I can testify that bands were very good to me during the pandemic. I used body weight and bands only, and it was really good. And they have an online support community here where they all help each other out. So this can be a very good thing. I don't know anything about it, but there again is an address for it if you want to check that out. That's an online course. So the only thing I'm going to say, I wrapped it up, but wait a minute. I'm going to unshare the screen if I can. How do I do that? Unshare the screen, unshare the screen. Unshare the screen, please. How do I unshare the screen? Stop sharing screen. Okay. All right, I'm back. Okay, just 1 minute. I just want to say that, you know, as a patient advocate, I don't have any expertise in this stuff medically, but everything that I do that, you know, in my regular work also is more motivational than anything else. And hopefully that can work. But I don't believe that telling people all the good things that are going to happen for them if they exercise does that much good. And even less so, all the bad stuff that's going to happen to them if they don't. I like to say the only thing I'm always selling is how good it feels. I mean, is it the ultimate quality of life enhancement? I see guys lacking motivation all the time, and it's very hard for us, I know, when we're older and when we're on ADT and so forth. But if we look at life as being, you know, we have longevity and we have quality of life. And so the longer we live, the more we want to live a long life and a good life, and we want to die quickly. And the longer we live, the likelihood of those other two things happening perfectly for us are not good. So I feel like concentrating on today and concentrating on having the best quality of life I can today is what matters. And exercise for me has made all the difference in that. And it just did something I had already done, but it came in more than handy when I had to start going through these treatments. So, you know, it's by far to me the thing that we have control over that is the most effective. So I guess that's all I got to say.
All right, that's great. Thanks a lot, Jimmy. Could you put that EXRX website in the chat in case?
I'm going to put that one. I'll put that one in there, and the Christina Cartwright's work at Dana-Farber ongoing in there also.
Thank you.
You're welcome.
Herb, you think we should give you a try now?
Hey, you just have to make me presenter.
Yeah, I'll do that.
And let's see if it'll work.
Wait a minute, now I can't even find you in the. Oh, there you are. Okay, I made you presenter.
Okay, good. I'm trying to share. Does everybody see? Can everybody see this?
Yes, yes, we see.
Good. Okay. So I'm going to talk about 2 clinical trials and then something that I thought was really interesting, even though it may not be terribly germane yet. Okay. So the first is the idea of these 2 trials are directed against neuroendocrine prostate cancer. And I think we all know that the neuroendocrine development is not a good sign, that if we can avoid going there, we'd be better off. But basically, most neuroendocrine tumors are not good for you, actually a very bad survival rate, and they express this thing called delta-like ligand 3, and there's a picture of delta-like ligand 3. And then on the right, you can see that it says that a high percentage of neuroendocrine prostate cancer tumors, 76%, express this. So this is a target now for a clinical trial. And here's another example of why it's not great for you. It's negatively correlated with PSMA and STEAP1, which are the early prostate cancer markers. And if you look at the overall survival in the lower right-hand corner of this Kaplan-Meier curve. What you can see is that the DLL negative tumors and people with DLL negative live longer than people with DLL positive. So this becomes a potential target. And in fact, through AmGen, there's a drug, it's a BiTE. It's called tarlatamab. It's a half-life extended BiTE targeting DLL3. And it's currently in clinical trial, and I'm given the trial number, sponsored by AmGen. There are quite a few sites around the country. So to me, this means there's hope for this neuroendocrine prostate cancer phenotype, which has been really tough to beat. So the preliminary results are good. I mean, here is the preliminary study of control BiTE, or this BiTE for DLL3. This is in animals, but doesn't matter. I think it's really it seems to me pretty promising in the future for neuroendocrine prostate cancer as a BiTE from AmGen. And the next thing is just something that came from Oliver Sartor, which I think I want to remind everybody of, that anti-drug antibodies represent a potential pitfall for BiTEs because they look different. They're not our natural proteins. They're not our natural products. And so they generate antibodies inside us directed against the drug. And if we develop these anti-drug antibodies, obviously that's going to prevent full efficacy. They're going to kill they're going to take out the BiTEs and make them ineffective. So it's something that we need to think about, and or at least people developing it need to think about. So the second clinical trial is adenosine. Now, adenosine is a drug, is in all of us. It's a common metabolite, and in fact, if you drink coffee, you're antagonizing adenosine. But it turns out during cancer cell progression, and this is maybe a complicated figure, but in the right upper left, we have potential sources of adenosine, and I'm going to point to it. And the adenosine then interacts with these things called receptors in blue and green, and then they change things inside the cell, and they cause this immunosuppression, cancer proliferation, and angiogenesis. So all of this is not good for cancer, caused by adenosine interacting with this thing called the A2BR receptor, here over on the far right in the green. So the A2BR receptor, when it's activated by adenosine, and it happens in most advanced prostate cancers, is not good for us. So therefore, A2BR antagonism improves immunity and blocks cancer cell progression. And I wouldn't be telling you this if there weren't specific rationale to develop an antagonist, and a company did. It's called TT702. Alone inhibited cold tumor growth, and a prostate cancer is a cold tumor, and it was more effective in combination with a PD-1 inhibitor. So they had synergistic effects for the reasons that I'm showing you in this slide. So once again, there's another mechanism coming along, and there is a clinical trial. Unfortunately, it's not a clinical trial in this country. It's supported by Cancer Research UK, but it just started last fall, and hopefully we'll have another drug available to us to help move us along in the right direction and keep us around. Okay, I said I was going to send the best for last, and this title is pretty heavy duty. Commensal bacteria promote endocrine resistance in prostate cancer through androgen biosynthesis. What are commensal bacteria? Commensal bacteria are gut bacteria. So this is a paper which I thought was incredibly important, showing that gut bacteria can make a difference. And the data for it come from animal studies. I mean, here I'm just showing you the normal way in which we think about testosterone production, right? We have the hypothalamus and the pituitary and the testes and the adrenal gland all sending testosterone to the prostate, which makes prostate tissue grow and cancerous. So this is the conventional wisdom, right? And then the next slide basically just adds the drugs that we've all been exposed to that tell us how they work to counteract this system. And I thought that's just something we should know as a background. But here, what they did, they took animals, and this TRAMP one is a prostate cancer cell line, and they put them into the animals. And they did two things with them. They castrated them, so essentially any tumor growth in these animals is going to be castration resistant because they've castrated them. And then they treated them with antibiotics. And what do we see here? That the fastest growing tumors are the sham, where they did nothing. The next fastest are they treated just antibiotics. The next fastest are where they treated with castration. And then here's the combination. What you can see, the combination of castration and wiping out the gut bacteria with antibiotics reduce the tumor size. And on the right is a survival curve. And what you can see in the upper right-hand corner is, in fact, that the longest survival in these castrated animals was when they were given antibiotics which wiped out their gut bacteria. Okay, and it synergizes with enzalutamide. And again, this is the size of the tumor, these land cap cells, and the green on the bottom, again, is showing you castration plus antibiotics. They're growing slowly. And on the right, what you can see is, after a while, notice the treatment in green with enzalutamide. Tumor shrinking, tumor shrinking, tumor shrinking, and all of a sudden it starts to head up again. That's castration resistance. But then look at what happened when they gave the antibiotics in this situation. The tumor continued to shrink. So something in those things that they're wiping out with antibiotics is helping along with castration resistance. Then they did what is called shotgun sequencing of fecal DNA. They take feces and they look what's in them, and they find these three species of bacteria in the gut are higher in the ratio of castration resistance over sham, suggesting that these bacteria may have something to do with it. Then what they do, an ingenious experiment, this is where we get to the point of thinking about fecal transplants. What do? They looked at dihydroepiandrosterone, and they looked at testosterone, which are the things that drive prostate cancer. And what do you find? Is that here, castration level, we have a castration level of testosterone. They give castration level and antibiotics, and it drops, right? But then look what happens. They give a fetal transplant from a castration-resistant animal, and it goes way up. And if they give a fetal transplant from a castration-sensitive animal, HD, it doesn't go up. And likewise, if they give these bacteria, which they found make testosterone, they go up. So there's strong evidence here that testosterone produced by these gut bacteria in castration-resistant animals drives cancer progression. And then here they looked at people. They looked at the lower ones are the bad bacteria, or the good bacteria rather. The upper ones are the bad bacteria. And the more you develop castration resistance, even if you're didn't make it, the higher level you have of these bad bacteria, and the lower level you have of these good bacteria in the hormone-sensitive state. So really, it adds a new dimension to what we have to think about. I thought, while it's not a clinically relevant thing at the moment, I mean, who knows? Maybe fecal transplants from hormone-resistant people into castration-resistant people can counteract this phenomenon. But I thought, to me, it was extremely fascinating that there's another source of testosterone that nobody thought about. And so that's the end of my presentation.
That's great. Thanks a lot, Herb. Very, very interesting. Did they mention the name of the antibiotic that they
Yeah, I
use?
mean they did in the article, and I didn't remember it.
What was it? An FDA approved on?
Yeah, these are FDA approved antibiotics that can wipe out your gut bacteria. Right. These are not the antibiotics were not experimental.
Wow, that's
I bet
great.
it was something like neomycin, which stays in
Right.
the intestine.
Right. Thanks, John.
It sounds like it would be interesting to look at the microbiota in castrate resistance and castrate sensitive people and
Well, that's
wonder
what they
whether
did
that's
here.
right. But it's something that potentially could be a useful screen, and if that's identified with rising PSAs, it might give a clue to try an antibiotic protocol.
Right, exactly.
as a step.
Or even a fecal transplant protocol. Because look here, CRPC. If you look at the dots, right? These are for individual people, right? These are humans, cancer patients, hormone sensitive patients on the left, castration resistance still alive on the right, and castration resistance that didn't make it on the right. So I thought this was really fascinating. You got to look for this ruminata, streptococcus, because those bacteria are the bad bacteria. And maybe if you see you have them, you can get rid of them.
Okay, very good. John Antonucci, shall I make you presenter?
No, I don't have any slides.
Oh, yeah. Okay, so you just want to chat?
Yeah, I'm not.
But you
smart
can
like
stop
those
me
other-
from being presenter. I have to see.
Yeah. Okay. I think you have to stop sharing your screen.
Okay, I'll try to figure out how to. Oh, okay, there we go.
Okay, good. Well, I'm not smart like those other two guys, so I wasn't able to make any slides. But they were awful technical anyway, so I don't know if they would have helped that much. My topic also has to do with hormone-resistant prostate cancer, and it's called glucocorticoid receptor biology and HRPC. Now, that's really a mouthful, and Rick took great pains to ask us to make this all very understandable. So I'm going to try to explain this as best I can. If I use any $10 words and don't adequately explain them, put them in the chat, and I'll explain them, and I'll donate $10 to AnCan if you catch me. So what does this mean? First of all, starting with what we know, we all know and fear testosterone, right? We desire it and we fear it. But what is it? It's a steroid hormone. And what's a hormone? A hormone is a chemical that's made in one part of the body, is sent out into the bloodstream usually, and has a job to do at some remote location. Now, so testosterone is a hormone. We all know where it's made because we try really hard to block it. And it goes to many different areas in the body, right? Because we know how sick we get both in our brains and our bodies when we block it. But what happens when the hormone, how does the hormone signaling actually happen? The hormone has to reach a target that recognizes it, right? The target that recognizes it is a protein called a receptor. So not only do all our normal tissues have receptors for testosterone, but our prostate cancer cells have receptors. And so they know when testosterone is circulating and when it's not circulating. So it's really receptor activity that we are concerned with, and it's really hormone receptor activity that these guys are paying attention to in their research. The goal of this particular kind of research is to find a way to get around hormone resistance. Now, testosterone is familiar to us, but it's by no means the only hormone, right? There's progesterone and there's estrogens and there's other adrenal hormones called mineralocorticoid hormones. And there is a particular hormone from the adrenal gland called cortisol. Now, we're kind of familiar with this. It's an extremely important hormone. And when it's blocked, we have to take, like when we take our abiraterone, we have to take some prednisone or something to make up for the missing cortisol. That's how important it is in our bodies. If you think testosterone does a lot of things, well, this is really an important one too. So these hormones actually, like everything else in our body, evolved, and their receptors evolved. Things were simpler 300 million years ago when just very simple hormone precursors existed, but they started getting more complicated and branching out. So out of these primitive hormone receptor complexes, estrogen branched out, and then later testosterone branched out, and progesterone branched out, and cortisol branched out. So you could think of these hormones and their receptors as kind of cousins. They're related to each other. And like one of my presenters pointed out, when you've got cousins or family members, they influence each other. They still have an effect on each other, almost kind of goes back to pre-evolutionary or early evolutionary days. So why do we care about any other hormone besides testosterone? Well, my first presenter is Nima Sharifi, and he's from Cleveland Clinic, and his work starts from this observation made by a number of people before that, which is that if you could imagine a seesaw with our testosterone receptor on one side and the cortisol, or what we call glucocorticoid receptor, on the other side, the relationship is when one goes up, the other goes down. There's a working interaction between these two hormones. By the way, why is it called, before I lose $10, why is it called a glucocorticoid? Well, as I said, these steroid hormones have many, many different effects. One of the effects of the cortisol hormone is to affect glucose metabolism. So that's how it got attached to the name. And corticoid came from the fact that it comes from the cortex of the adrenal gland. Hormones or steroids are little simpler molecules, but receptors are proteins. Proteins are very complicated molecules. They have many, many, many different components, and they have a three-dimensional structure. When the hormone meets the receptor actually alters its three-dimensional structure a little bit in order to start the signaling process downstream. That's then going to happen. Now, proteins in the body are coded for by genes. One gene makes one protein. So if you're going to be interested in receptors, then you have to also be interested in the genes in the nucleus of the cell, including the cancer cell, that code for those particular receptors. Now, this interaction between the glucocorticoid receptor and the androgen receptor, or testosterone receptor, is very influential in the process of hormone resistance, the thing that we all love to hate. Dr. Sharifi elucidated a lot of the mechanism of the relationship between these two receptors in the cancer cell. It was very, very interesting stuff. You know, one enzyme increases as the testosterone is suppressed by enzalutamide, and in that process, he discovered that there's a particular enzyme. Now, an enzyme is a protein. It's a protein designed to do a different job than a receptor protein. An enzyme is designed to make a chemical reaction take place. Now, it was observed that there's an enzyme called H6PD, hexo-6-phosphate dehydrogenase, which is found in overabundant amounts in the state of hormone resistance. So as our androgen receptor activity is suppressed by our enzalutamide, this actually turned out to be true for abiraterone, and things. As we, hormone resistance is caused by us, right? It's caused by us and our pills. And so it has a whole number of different effects. But this H6PD enzyme, it turns out that this work was done in what are called xenografts, which is a combination of two different creatures, human prostate cancer growing on mice. That if you knock out this particular enzyme, H6PD, with gene editing technology, what we call CRISPR, the prostate cancers don't grow as well. They shrink, they get smaller in number, and but you can't do that to a human being because it'll kill us. But if we interfere with this enzyme in some way, we might be able to reverse hormone resistance, or maybe even prevent it in the first place. Now, so the search was on for something that would reduce the amount of this enzyme. And they came up with rucaparib, a drug that's currently on the market for ovarian cancer. You can tell that it sounds a lot like olaparib, which is a drug that we use. So it seems to work to shrink tumors in these xenograft mice. And it's not ready for human experimentation, at least at the time. But pretty soon, I think we're going to start seeing early studies of using rucaparib in humans and seeing whether we can reverse the process of hormone resistance. Now, my second presenter was Suzanne Konzen, who's at University of Texas. And it's along the same lines. She's very interested in this glucocorticoid receptor and its intimate relationship with the androgen receptor. So she studied a whole variety of different prostate cancer cell lines, looking for what she calls selective glucocorticoid receptor modifiers. Glucocorticoid receptor I've already defined, and so she wants to modify the activity of those receptors in such a way as to see whether it affects prostate cancer. So after looking at a whole lot of these and animal models as well, in an effort to modify the glucocorticoid receptor genes that manufacture those receptors, she came up with a drug called relacorilant. And this one is ready for human study. So she's about to start a phase 2 study where they take people but like us with high-risk cancer before our prostatectomy and start them on ADT and enzalutamide, and then one group, it's just them, and the other group goes on relacorilant. And then they will study the glucocorticoid receptor gene expression after the radical prostatectomies and see whether we can unlock the puzzle and prevent future resistance. My last presenter is Wayne Tilley, who is at University of Adelaide in Australia, and he is really interested in that glucocorticoid receptor and its influence on prostate cancer, but also interested in the estrogen receptor and breast cancer. Most breast cancers are estrogen receptor positive, just like our cancers are addicted to testosterone. a lot of 80% of breast cancers are addicted to estrogen. And there similarly is a seesaw relationship between estrogen receptor activity and androgen receptor activity. In fact, there's androgen receptors on these breast cancer cells. So he asked the question of, can the androgen receptor somehow be reprogrammed in prostate cancer in the same way that some of these breast cancer studies have done? And so he looked at thousands of receptor ligands. What's a ligand? It's the thing that attaches to the receptor. He looked at thousands of them. He called them SARMs, selective androgen receptor modifiers, and found some very interesting good candidates. Even found some really interesting activity that where some of these, what he called SARMs, androgen receptor modifiers, clearly inhibited prostate cancer growth. There's no human study yet, but he's got, now that he's got some very good candidates for androgen receptor modification, there's probably going to be before too long some human activities, and that will be yet another way to use alternate receptors in order to try to dodge the development of hormone resistance. So that's it.
Okay, thank you very much, John. We're going to go to Mark Perlow to wrap it up before we move on to our regular session. Mark, do you have anything?
Could I ask a quick question of John?
Well,
John,
we've only got 8 minutes for Mark. Gary, why don't you hold on till later with your question?
Okay.
Mark,
Send it to me.
Can you share your screen?
I can't see how to do that.
I'll make you a presenter.
Okay.
Hold on.
I'm on an iPad. Do you know where that will show up that I can say, yes, share it?
Well, maybe it'll be obvious. Okay, let me just make you an organizer, and I'll make you, let's see, what happened to you? Oh, now you're up here. Okay, I just made you presenter. You see?
Okay, I am unmuted and tap to share content. iPad screen. Okay, you should see my screen now. Now let me get to the, okay, do you see the slides?
Yes.
Yes.
Okay, great.
Can you make
So,
bigger? You spread out your,
I'm sorry?
can you fill the screen with your slide? It's kind of small.
No. Well, I guess I can here. So what, when I got on this, I wasn't sure exactly what we were going to hear and had some technical issues setting up at first. But I listened to 2 talks. One was looking at clinical genetics versus functional genetics, and we'll get into that in a second, what that means. And then the other was based on artificial intelligence. Unfortunately, neither had much on the way of being on the horizon for us in the very near future. In this study, they noted that they looked at various genes, and we are familiar with things like P10, MYC, TP53, and some of the others on there. The interesting thing that they found was that there was a significant increase in the copy number for the androgen receptor gene. In all the other genes that they looked at, they saw some gain and some loss, but they decided they were going to look at how the genetic changes affected copy numbers for androgen receptors. Now, they looked at an amplification, which means that you take the DNA and you create multiple copies of that DNA and find what gets amplified. And they saw that there was a particular segment, not the androgen receptor itself, but another, another segment of DNA that was elevated in patients that increased the expression of the androgen receptor. We heard about the glucocorticoid receptors, but they can be expressed variably, meaning that some patients will have more receptors, and I like to think of it as lock and key, and this androgen receptor enhancer means that we have more locks that the key can do something. This was looking at another kind of amplification, and again, it's a very technical slide that's not really relevant to get into, but they found most of the changes were due to increased activation of this androgen receptor enhancer. So it's about 2 steps away, and they looked at certain areas of the DNA, and a methyl group is carbon and 3 hydrogens, and when you have that methyl group attached to certain segments of the DNA, you quiet a gene. When you take that methyl group away and have focal hypo-methylation, what it says is a particular gene is going to be more active, and they found this and showed that the status of methylation on the DNA is important. So it's not always just looking for an error in the DNA code, it's how that DNA code is expressed, and is anything more likely to make the DNA code expressed. You can see in their studies they had very few patients. They were trying to find copy number variations by looking at either metastatic tissue or cell-free DNA. And if you look all the way to the right, you see that they found changes in the androgen receptor location. So they feel that they want to look further, and this is something that they can pick up through a simple blood draw and find circulating tumor DNA in the blood rather than having to have a biopsy to find the androgen receptor status. So the clinical genomics is looking at the genetic sequencing, either of RNA, which is the transcribed message from the DNA. And on the one side, that's primarily what we've done in all our tests is look at gene sequences. They would like to go with a different approach and start with what are the factors that are affecting things like castrate resistance, androgen receptor expression, and what causes the resistance to enzalutamide. So the answer is not always going to be that there's an abnormal sequence that we can pick up by doing genomics. It may very well be looking at the methylation status to see whether a gene is turned on. In this study here, this was actually towards the next study, and this was interesting. They looked at, they were based on artificial intelligence, and they wanted to know whether there were different areas of the tumor that they could look at and look to metastasis-free survival. So they showed that the luminal, if there was luminal disease, it responded better to apalutamide and ADT versus the patients who had basal disease. So then they went and said, well, can we use artificial insemination to replace pathologists? And they took a number of slides. They broke the slides into smaller areas and looked at getting panels of pathologists to look at these slides and see where there was agreement and where there was disagreement. Where there was agreement, they used that to teach the artificial intelligence what they were looking at. And they took a number of different models and thought that in a number of different cancers and tried to see if they could replace pathologists. And basically in the yellow and the light brown area or beige area, they have a lot of areas that they've tested, but the only area that came back that they could detect and get FDA approval for detecting the cancer with the artificial intelligence was prostate cancer. So they have 1,000 whole slide images, ROC or rock curves. The more right angle that curve is that you see in the center there, the greater the sensitivity and specificity and the better test. If the test results when you create this curve are like the dotted line or hash line in the center, it means you have a test that isn't good. With this, a rock curve of 0.90 is very good. So this says that the machine learning was able to do quite well. And here were some of the rules that they had, and we all know the Gleason scores, but they were trying to grade this with a computer. And they actually found that it did well, and that the scoring this way worked out quite well. What they would hope to do in the long run is not only be able to have the AI predict grading and Gleason scores, but also determine whether there are factors that you can find on pathology that will help predict things like metastatic resistance, response to various medications and all. Again, it means a lot of data and a lot of looking back and plotting that against outcome data that they hope to have in the future. So that's what I have.
All right, thank you very much, Mark. Rick would like to fine you $10 for using a $10 word, focal hypo-methylation, but you know, maybe cut you some slack.
Rick, next time I come down in your area, we didn't stop this time. Everything got canceled because of COVID. I will stop off and give you that $10.
Okay. Listen, I do want to say something. I want to thank all the presenters from this week and all the presenters from 2 weeks ago for doing such a fantastic job, volunteering their time, explaining it to us peons who have trouble. We will go cross-eyed when we look at some of these graphs. You guys did a fantastic job. I also want to thank Ben Nathanson, who is separating these recordings, and we'll make a little blog post, and we'll put both links to the recordings on the blog post, and so you can watch this stuff a little bit later again if you so desire. And thank you, Len, for organizing everything.
Sure, my pleasure. And yeah, Ben also helped a lot with the organizing, setting up the folders on Google Docs.
Great. Thank you.